If you're ever up on stage, you get the opportunity to work from the podium. I do the same thing on the podium that I do in my office. So I rehearse in my office as if I'm on podium. That means the way that I inject to keep my hands out of the way of the camera and knowing where the patient is and inject from both sides, like I've seen Kent do as well. Okay? So to present a patient, if you're ever presenting a patient on stage, don't let them talk. Get all the information you can beforehand, and then you can present the patient. Because if you ask the patient a question on stage, you don't know what's going to come out of the patient's mouth. They may have forgotten something, and they'll tell you, oh yes, I had that toxin put in. It was the worst experience of my life. I hate fillers, because you don't know what's going to come out of their mouth. So never ask a question on stage. The only question that I'm going to ask her as we're going along is, are you comfortable? Am I hurting you? Can we get you any water? Are you feeling okay? Because she is my patient. Grandpas, gender, race, age, medical history, previous injections, aesthetic wishes, and facial shape. Let's go through it together. Gender. Is that a hard one to figure out here? No. Okay. Race and age. So what do we have here? We have a 66-year-old white female. Got it? Medications. I asked her about medications. What am I looking for? Possibility of blood thinners. Do blood thinners push me away from injecting a patient? Absolutely not. I inject patients who are on Coumadin. I inject patients who are on Plavix. I do these things, but I understand if they can stop them, I prefer that. I worry more about the homeopathy stuff. Anything that begins with the letter G is a killer for me. Garlic, ginseng, ginger. Those are the things that cause omega-3s, fish oils. I worry about those more than I worry about aspirin, to be honest with you, non-steroidal anti-inflammatories. If a patient can stop them, sure, then you go ahead. But some patients can't. I have patients who have heart valves. I have patients who are I had a patient that I had on stage that they threw at me that had 3 pulmonary emboli in 6 months, and the guy was on Coumadin up to his eyeballs. They said, oh, you don't want to inject that patient? We're sorry, we didn't understand that. I said, no, absolutely. I'm just going to show you the techniques that I do that will allow me to inject a patient and try to minimize bruising. If you're on a blood thinner, you will clot. It just takes you longer. So you be prepared with ice, with pressure, with these types of things that you can do. So we asked her about her medications. And her medication, I believe, was a statin. You're taking something for cholesterol. And there was something else. You were taking some hormone replacement, I think, or something? Correct. Okay. So medications. Allergies, she said, to sulfa. No? Or Thorazine, right. Okay. And sulfa. Okay, so we have medications, allergies. How about P? Previous surgeries. She's had threads put into her face 6 months ago. Suspension threads. And she's had some facelift work done. That was done how many years ago?
4 years.
4 years ago. Perfect. Tells us there's stuff in there. Got to be careful. Scarring that you have to be careful about. That means that you should expect if you're going to start using cannulas and stuff that there might be a little more resistance to it. So be prepared. Okay. Anatomy might be a little bit different. And then we ask her about skin conditions. Do you have any history of having cold sores or anything like that at all? No. So we're good around the lips. Her aesthetic wishes. This is the interesting thing. She said, do it. Carte blanche, because we're up here right now. But I got to tell you, I'm seeing more and more of that in my practice. And the reason is because the patients have bought into and understand my why I do things. Not how I do it, but why I do it. Not what I do. I just was telling some of the audience that I did a little survey on my practice from the week before I came here. I saw 78 patients in 2 days, a day and 3/4. Out of those 78, 15 were new patients. But of the entire 78, over 40 patients, when I said, how can I help you today? What do you have in mind? They said, Dr. Swift, I leave it up to you. Whatever you think I need, I'm willing to go with. Really? What happened to the budget, guys? That's them buying into my why. They understand that I'm going to do whatever I can because what my why is I love doing what I do. I'm passionate about it, and I want to make them a better version of who they are. Wouldn't you love to have carte blanche like that? I said, is there a budget over here? They say, I know that you're going to manage it as best as you can. Wow. Okay. So, I'm sorry? How many of those were referrals? That's an excellent question. 4 out of the 15. 4 out of the 15 said do it because they said, I heard about you. I understand that what you like to do is to do a full face approach and that you want to make me look as good as I can look. I'm in. They're calling and asking for that. It's the why. People buy into why you do something more than what you do or how you do it. Okay? And now if we were to take a look at her facial shape, let's get her on the camera because that's the last one from Grandpa's. Her facial shape. Let's focus in, guys. Let's come in a little tighter. Can you get me a shot that's from about here to here? Keep going. Attaboy. What facial shape does she have, guys? She's fairly oval. That's good. She's had surgery done. She has a little bit of this stuff over here and that. Kent's going to run through his assessment of the patient. I gave him the history behind it. Let's hear what you got from me.
Oh, sure.
Go ahead, buddy.
Okay. So our threadless were done, 6 months ago?
Yeah.
And your face, how long ago was your facelift?
4 years ago.
4 years.
4 years ago.
And she's had injections done before, as we can see.
Okay. And then what
And
about
a
your
lot,
nose?
she
What have you
said.
done
A
to your
lot.
nose job there?
No job.
No nose job. Okay. So what have you had put underneath your cheek, underneath your tear troughs here?
She's looking to her
fillers
husband
in
to
here?
find out what he put in there. Restylane? Okay.
Okay, what about in here?
Restylane.
Okay. So when was your last Botox there? Or Dysport or whatever
Hello?
you've had?
4 weeks ago.
Okay. Scowl for me a little bit.
Try to make
That
a frown.
scowl. Okay, raise your brows right up. Okay, good. Smile a little bit. Oh, you could do better than that. Okay, good. Now, if we talk a little bit, if you think about it, we've never seen ourselves except in a mirror or in a photograph unless you're a twin. So we don't know all these little quirky things we do. With animation, because we just carry on our lives kind of automatically. So you can see as you watch her there, she has the tendency to pull the mouth corners down, but she may not do it out of demand. There, can you do a mouth frown? A little bit, not a lot here. But she was doing that a minute ago with pulling her mouth corners down, so you know she activates her DAO here a little bit just by habit. And so I would, if she's my patient, which she is right now, Faye, because we're going to bond a little bit here, is we talk a little bit. We'll just kind of bypass what she thinks her best features are and what she'd like to see better, except I'd like to have her tell me what you'd like to see better. What would you like to see better about your face? Now, what is that?
This is my temple.
Yeah?
Because here is kind of coming out and this is in.
So you feel like your temples are a little hollow?
Yes.
No. Not really. You know, if you have them a little convex, you're going to look masculine. You want to have a little concavity or a little flatness there, otherwise it doesn't look feminine. So you don't have much in the way of depression there, so I'd be a little careful. You could do a little bit of filler there, a little bit. Okay, where else? Here, on your jowls. Yeah, see now she's doing her DO thing here. She's creating this little pattern here she's got. This is an eyebrow pencil. And that's from pulling that muscle down, and eventually that gets a little bit saggier and looking there. So I think we'll just, in lieu of time, we'll do, have you ever been measured for anything?
No.
We're gonna measure your face a little bit, just gonna do a little drawings here. Okay. But before we get too carried away, I think we'll do that first. So with your...
Question, folks, does she wear her hair up or down? What do? Do you wear your hair up or down?
Down.
Down. Why? Watch what Kent is going to measure now and you'll see.
We won't. It looks like I'm going to stick you here, Faye, but I'm not. Just keep your eyes open there. It's going to measure that intercanthal distance we've been talking a little ad nausea about. So that distance should be the distance between her brows. And it's lined up pretty good. The head of the brow should be lined up to the intercanthus there. And that distance should be the width of the nose and the maximum volume of her lower lip. And that phi part here should be the length of her eyebrow from where the eyebrow should start. And she's missing a little bit of eyebrow there, but I wouldn't fuss with that. Then the height of the forehead which we've already determined is a little bit high because you guys have all got 5 eyes. So middle of her brow is a little bit. And it's not good or bad. She's just got a high forehead. So you can either do a hair design or get a chainsaw out. So I don't think you want to get the chainsaw. So your brow position. And we can talk about she's got a little deflation in her mid-forehead here, well, her lateral forehead. The mid part's fine, but she's a little deflated through here, and we'll draw that out a little bit. So the apex of her cheek should be that same length of the brow from the corner of the eye, 45 degree out. And it's pretty good, but we'll draw that in and show you a little bit about that. Now, is her nose relatively long or short? Long. Yeah, and that's not good or bad, but that's just part of her features that I noticed. That's why sometimes when you ask patients if they've had any nose work, they don't remember because it was done as a child type of thing. But you measure that length of the nose from the eyelash, just even above that a little bit. You can see that her nose is a little bit long. So there's ways to give that illusion of being a little bit more in line with your eye, your phi of your eye. So the length of that brow should be the width of her lips. And her lips, this is one of the issues, and Arthur's going to talk about whether middle third, upper third, middle third, or lower third is her main issues. So to me, this lower third is a bit of an issue here, because her looking a little bit puckery with her lips, because it's hard to see maybe from the photograph, because photographs are two-dimensional. But she's retruded in the base of her nose, is all retruded here. So it's making her upper lip look a little full. And it really isn't. And then the actual chin you can measure a couple of ways. I measure it from the eyebrow width. And it's a little bit wide. So it's looking a little bit flat. You can see as you look in the side view there, her chin is a little bit masculine. So we want to feminize her face because she's got lots of feminine features, but that's one thing that's making her look a little bit more mature and a little bit masculine. So that's one of the things I would look at a little bit. And if we measure her nasal labial angle, it should be about 95 to 110 degrees. And we'll try to do it from the side view here and show you here.
You can turn your body.
Yeah, just about like that. And you can kind of see here.
There we go.
We'll measure that here. And it's basically right at 80 degrees. So it's a little bit, that'll help with the nose shape to lift that up a little bit. And you want to make sure there's lots of room above that nasal spine. So you have room to lift a little bit. And that piriform fossa and the base of her nose a little bit. Then I would draw, and we'll try to just, with time, we'll just draw here a little bit from the lateral canthus right to the middle of the tragus, right down to the corner of the mouth, and then drop this line straight down. This will give you a little better idea of what you're doing with her mid-face here a little bit. So the lateral canthus to her mid-tragus. I'll try to stay out of the way of the camera here. And then draw that line like that, straight down, and then just do a little circle like this, and you can start to see and say, okay, what side of her face is fuller? Right side. So 80% of the time,
keep in on it.
One side is going to be fuller as the right side.
It's focused in on the patient.
So kind of focus in on that. You can kind of zoom in a little bit so you can see that. That's good. So you can see the reflected light there and see this left side's a little bit out of balance a little bit. This is your older sister. It's also the driver's side. And this is the side you sleep on too. Mm-hmm. Correct? Yeah, it's the side she sleeps on. I know just by looking at her face, this is the side she sleeps on. She might be a flopper, but this is the side she sleeps on. So that's you can diagram out her apex there a little bit. But the issues to me are this wide zone through here, and this nasolabial fold is not. It's a ditch. It's not a line. And the lateral commissure and the marionette zone, these are zones. They're not lines. So she has no crease in the nasolabial fold. So you can actually lift that up quite nicely and get a really good end result here. So those are the areas that I would kind of focus on a little bit today, trying to improve this a bit. I wouldn't touch her temporal fossa. I don't like this sagginess of her. She's got typical, she's probably had a nice facelift. It was good, but an undermining there, they've lost some of this subcutaneous tissue here, and she's blunted the angle of her gonial angle and her jaw angle here. So she's blunted that a little bit, and it's a little bit lax, as Arthur was kind of pointing out. So we could clench your teeth there. Yeah, she hasn't really no masseter to speak of. But you could do a little bit of filler to give her, like I was demonstrating before, to give her a nice, more youthful jaw angle. So how old are you going to be on your next birthday?
51.
51? Okay.
She wishes.
After you're done with me, I'll be 50.
No, okay.
Oh, she says when you're done with me, I'll be 51.
Uh-huh.
I'll be 62.
That's more like it there. But I won't tell anybody.
I'm
Only your
67.
hairdresser and your aesthetic physician should know your age. So those are kind of the areas that I would kind of focus on, Arthur.
Sure. Okay. Great.
Now look at the drawing. Looks like, then you have to explain. It's like when you get through injecting patients, all they know is you just stuck a bunch of needles in them and cannulas. So you have to go back after and explain sort of what you've done. So in the mirror, so they can sort of see what you've done. You just assume that they are going to know what they've done.
Okay. Outstanding analysis. I'm going to go through some things now very quickly. I'm going to try to do it in a systematic fashion so you can get into the idea whether it's my system, Ken's system. We all have our systems on how we do this. Stick with it. Don't change the way you do things just because Kent and I are doing it a certain way. Develop your own type of system. Let's look at face maps on this patient. Facial areas, upper, middle, lower third, and periorbital. Let's give it an aesthetic scale. While we're cleaning her up, take a look at her face. Can you focus in on her face, please, guys? And let's stay here to here. That's it. He's going to take it off. But looking at the way that he was looking at before, if you had to grade the upper third of her face out of 10, what would you give her?
These are nice for those pencils.
Come on, guys. Throw out a number. 8. I have an 8 over here. Perfect. Mid part of the face. 7. Lower face. 4. Periorbital area. Look into the camera, sweetheart. Look into the camera up there. It's right there. Good girl. Okay? So we have 5 or 6. So if you have a syringe or 2 and you have to concentrate on this patient, where are you working? Lower face, periorbital. Isn't that interesting? Because we said periorbital area is the first area to age and lower face is the second area to age. So now we have that. Now we got to look at each of those thirds with respect to contour, envelope, movement. Take a look at the contour of her forehead, as Kent was pointing out. She has a little bit of flatness, as he noticed over here on the lower third of the upper third, right? That's very typical. We flatten here, we become more convex here, a little more convexity here. It gives her a little more of a masculine look. Can we put in a little bit of filler here to soften that? The answer is yes. Will we? We'll see. Next, temples. Are the temples, like Ken said, are they flat, concave, or convex? What are they? They're flat, slightly concave. Okay? I've changed my approach to temples now. My temple approach always used to be with respect to contour. Now I'm using very small amounts of product to adjust the eyebrow with filler. That's the myomodulation. I'll try it on her. I'm not going to go ahead and increase any bit of the temple volume over here. I'm going to put in a small amount of product into the temporalis muscle to see what happens if I give a little support behind the temporalis, which is a chewing muscle. Interesting. Watch. We'll see if we can do something with that. Okay. Then we take a look.
While you're on that, I think the reason that Dr. Smith is talking about this is because you look at her photos, her eyebrow does disappear in the no man's land here. It just kind of disappears. So that's the reason I would too, just a little bit to sort of just perk up her brow a little bit. But you're not trying to reflate the zone. You're trying just a little shape.
Shaping is right, because in females, what we like to see are gentle curves. We like to see these OG curves. That's what we like to see on their bodies. We like to see it on their face too. And men, we like to see sharp angles. That's more masculine look. She's showing a little bit too much of the supraorbital ridge laterally. That's what she was telling you when she came in. I want something here because this is too full, she said. It's looking too full. So we're going to put in a little bit into the valley, not to make her not to make her convex, but a little bit into valley, take off some of the edge on that lateral brow. When do you treat temples? You can treat temples if they're very scaphoid and you want to volumize them. You can treat temples if you want to contour the eyebrow. And you can treat temples if the eyebrow disappears around the corner. This is what Stephen Liu taught me. If it disappears around the corner when the patient looks into the mirror, it's a beautiful feature, that outer third. If you put a little volume in here, her eyebrow is going to pop out and she'll be able to see it when she looks in the mirror. She's going to love it. Upper third. Let's not dwell too much on that. Let's take a look at the envelope. What do you call her skin over here? Is it thin, thick, or average? What do you think? I have the advantage. It's Kent. What would you call her skin about over here if you were to look at it?
I'd say it's average.
Average. That opens up the whole portfolio of products to me. If it was super thin skin, she's a sextagenarian. But if she was in her 70s, let's say, a septuagenarian or an octogenarian, and she had super thin skin that you could read a newspaper behind, are you going to use a very robust product? Right. What if she was a male with very thick skin over there? Are you going to be able to use a very soft product? There's your answer. So you have to look at the envelope. Then we look at the movement. She's had toxin in, so we won't get into that already. And then we have to assess the amount. How much product am I going to need for her temples and her forehead? I would say probably somewhere in the order of 8 cc's. No, I'm just kidding. I would say
0.4, 0.5.
0.4, 0.5. I agree. About a half a cc should be able to do it. I want to put in about 0.2 into each temple, not to inflate them, but just to take off the edge, see if I can elevate the brow, and I'll probably need 0.1 or 0.2 for her forehead. That's it. Okay. So I'm thinking this way. Face maps. Face, facial area, aesthetic scale, contour, envelope, movement, amount. Choosing my product according to the skin. And then what's the safe area for me to inject over here, guys? What about on the temple? Where? I hope they're right, because I'm doing what they say. Let's get started.
So
Let's work on the upper third.
BD2 for your temples, or what do you want from BD2?
So what are we going to use for the temples? You have a choice. When I look at temples, I look at temples according to the contour of the temple. You can have temples that look like the saucer that you have in the morning for breakfast with your cereal. It's sort of like a shallow saucer that's quite wide in breadth. Do I want a product that's just going to be projecting, or I want a product that's going to project and spread? Project and spread. What if she had a very deep temple the aesthetic temple was very, very small, like those cups of soup that you get in those fancy French restaurants, right? What do I want? A product that spreads or a product that projects more? Right. So you're thinking about the quality of the skin and the shape of the area, the contour, and then you're choosing your product to select it. Now, if you're going to do a full face, you kind of can look at it and say, well, I'm going to do a little bit of an inventory, because whatever I use here, I might be able to use it over here, or I might be able to use it over here. There's no defined borders. I think Kent would agree with me that sometimes you can treat something with a different product. It's not like, for example, if I was to use the Allergan products, that Voluma ends here and then Volif starts. There's a blend in between. You can use products in the same area. I'm talking about off-label use now. So you have to decide. What would my product of choice be over here? I have a choice of either using Galderma's products, or I have a choice. I'm going to use both. I'm thinking that I want to showcase both products. I want to use something thin on the forehead. I'll start off with the forehead injections. I'm going to have a marking pencil, and I'm going to use, actually, the product that you prepared for me, which is
a 30% blend.
That or let's try with the forehead first. Let's go with the silk.
Okay.
I'm going to use Restylane Silk because she has average skin. I want a product that spreads very easily. Okay, I'm going to mark out her temporal crest over here and over here. Got it? Can I inject her over here, guys? I can inject into the skin, but I can't inject into the bone. I'm going to play the intermediate guy, okay?
Probably use those two rooms.
So I'm going to use a little BD2. I'm going to show you how I use it.
Okay.
This is the Restylane Silk. This is the way that I do it. I like to use a 31 gauge needle. I actually brought some 31 gauge needle, but I'll show you why I do it this way. Okay, here we go. Pull out the plunger. Keep the plunger sterile. I'll give you that little cap to hold. Backload your syringe into the BD2. Can we focus in a little tighter on the syringe, please? I'm going to start to inject. You're now going to see Poiseuille's law in action. Because as I inject, which way is the product flowing? Back towards my hub. The second that it gets up towards my hub, I stop. That is still sterile. I have not touched the patient with it. So is this. I now load this in. Watch what happens to the product. Look as it advances and the air goes out, and I usually have about 0.12, which is what I have. 0.12 is almost perfect for me to do half of it or almost all of it. I have it on a Suave 31 gauge needle, small needles. I like to use these around the forehead and the periorbital region because you have a lot more control with it.
It's like using a fine paintbrush, really. And that's right. 8 millimeter length. And the bevel is so blunted that that's a big advantage as well.
I have a pencil. A white one? Or we'll use the black. Okay, so that's my next point. This is me again. This is my practice. That doesn't mean that it's right or wrong.
Kind of quirky.
I'm quirky.
It is quirky.
I'm quirky. You can use this product pure because it's a nice thin product, or you can blend it. Okay? This product is partially blended because I have a little bit of lidocaine in there and a little bit of lidocaine with epinephrine so that she doesn't bruise or bleed on stage. How much? I don't know. How much is a good question. 1/3 or half. If the patient's skin is really thin, I'm going to go half. That's what I'm talking about. Half and half. Gotcha? Okay. If it's a patient that has a little bit thicker skin, I'll go with 1/3. That's my quirkiness, guys. I'm a witch. I just like to sit there and blend. I don't have orange juice in the morning. I got to pour a little carrot. I got to pour a little apple juice. I got to pour a little something in it. I just like to blend. It's my problem. Can I have a cleanser, please? We clean the dickens out of this place, okay? Because these are medical procedures and you got to give it the respect that it deserves. So I'm constantly cleaning. The pads have a spray of chlorhexidine on it so that if I ever touch the patient with a gauze, I make sure that as I can feel these are a little bit moist, that they have chlorhexidine on it. My approach is going to be what? Superficial or deep? I'm going down to bone. I'm using a small needle. You're going to feel a small little stick over here. I'm going to give her a little pinch as I put the needle in. It's in. You can focus in a little tighter if you can with that camera. Come into the upper third. Look how much of the needle is sticking out of the patient. That's a very small needle. I'm injecting very slowly. What am I looking at? And where else? Right. I'm injecting here. A quick glance over here. I'm injecting here. I'm watching how the product is reacting. There's a little bump that's forming over here. I'll over-inject just to show you. Slow injection. I might have gone through a branch of a vessel. Doesn't make a difference. So what am I holding in my hand? I'm holding a gauze prepared. I remove. We didn't hit anything. And I compress. That is a forehead injection. Finished. Did you feel anything? Give me a pain from 0 to 10, where 0 was no pain and 10 you want to hit Dr. Remington. 0. You're very stoic. My patients usually say somewhere between 0 and 1. If you pain them, you won't retain them. If you bruise them, and if you make them look weird, you will be feared. Correct. Good. We turn the head a bit more so you can get a better view of what I'm doing over here. And I'm going to go ahead, and I usually space them about 1 centimeter apart. I don't know how you do it, Kent. You can do this with a cannula, too.
I usually use a cannula.
Yeah.
But I do them both ways.
Exactly. Small little bump again, retract, and press. I'm prepared that in the event that I catch something, and I'm in tiger country here, this is where the supratrochlear might very well be. I'm going to go ahead. I'm going to fire in again. Small injection. Look how it ran a little bit vertical now. It ran up and down, but that's not because of the fact that I'm in the artery. It's because there's little septi over there, and I press and I do that again. And that's it. As I'm going, I usually have little circles that are drawn when I'm demonstrating, but it also is a good thing to do in your practice because you erase each circle as you go along. You inject in between. And that way, if you're injecting and a nurse pops in and interrupts you to tell you that your facelift patient has a huge hematoma and you want to get nervous about it, you go back, you say, where was I? I forgot. Well, the erased ones are the ones that you did, and the ones that are still circled are the ones that you have to do. And that's pretty much the story.
These BD2s, those are you're using them,
Keep focused in, guys. I'm not interested in me or Kent. I want to
are
keep on the patient.
inexpensive, and so I go through probably sometimes up to 100 a day of these things.
Yeah.
And one of the reasons he only fills it to the 0.12 as well is these are actually meant to be injected how many times? The insulin syringe? Once. So if you fill this up to 0.3, then you can't, you've got to use the whole thing, and it's dull. It gets dull.
It gets dull right away. And that's the best part, because as you finish the product, you can discard the needle.
Right. Discard everything. Yeah.
Right. If you're using a 31 gauge needle, which I put on a lot of my products as well, when you discard it, you lose the product in the hub. And I'm a miser when it comes to product. So she's being very good. She hasn't bled at all. And this is the technique that I personally use. You can go, but let's take a look and see. I don't know if she has toxin in her forehead, but we're going to find out. Can you raise your eyebrows? There. See how they both move? Both of the eyebrows move because I'm under Galia. Remember, some of this stuff, a lot of this stuff is lidocaine that's in there with the product. And she's still moving her eyebrow because I'm under the Galia. Okay. Well, we won't belabor the point because I'll very quickly inject the other half.
Want for a temporal fossa.
So for temporal fossa, I'm going to use Voluma. Let's try another company's product. I'll use Voluma. And I blended my Voluma because that's the way I do it. When I look at normal skin, I blend it 1/3.
Okay, good.
1 cc of lidocaine with a teeny little bit of epinephrine to 2 cc's of Voluma. We did this while Kent was giving his talk. She's going to give it to me. You can inject it through a 30 gauge. A lot of these products, both the Galderma and the Allergan products.
You want it straight up?
No, I'll take the blended stuff.
Okay.
Here's my champagne Voluma. Can you see it? I call it champagne product because it has little teeny bubbles in it. See the champagne?
Oh, yeah.
We're going out for a glass of champagne, dear. Don't expect any roses, though. We're just going to, or chocolates. Let me have a cleanser, please. I'm always keeping pads on the patient's shoulder being ready. This is the cleanser? Where's the cleanser? Somewhere in there?
Yeah, here. You can see that one better.
That one I can see. You can give me a little more than that. That's okay. Where am I injecting here, guys? Direct me. We're going to turn the patient's head a little bit sideways. Okay. We're cleaning. I feel for her crest. It's right there where the mark is, where Kent marked it. I'm going to go 1 centimeter up, 1 centimeter back. Wow, look, there's a vein in the way, so I'll adjust it just a little bit. I'm going to put my finger on to make sure there's no pulse. Then you make sure that there's a pulse down over here. Usually patients don't bleed if there's no pulse down there.
Very good. I told you he's quirky.
I'm quirky. 1 centimeter up, 1 centimeter over. You can put the patient's head forward if you want. Patients of color, you can't see the veins. Put the patient's head forward, they'll gorge the veins, and then you can mark them out.
Do a Valsalva, put the head forward right between their legs for about 30 seconds, lift them up, and then mark out any little veins with a little tiny pencil. So you can kind of avoid them if you're having trouble see them with the light.
Okay.
We do that a lot.
So I put the needle. I must be down on bone. I'm going to press a little bit over here. Look, I can't put my needle down any further. This is a 30 gauge needle. 30 gauge 1/2 inch. You can use a 27 if you like. This is the thing that I forgot to tell you this morning that I'm going to include now, is the fact that I've gone down through skin, subcutaneous tissue, through the anterior, or what's called the superficial temporal fascia, the deep temporal fascia. Maybe I went through a vein or two. There's a sentinel vein that's down there. The sentinel vein is a vein that's a branch of the middle temporal vein. It's located in that area. It's deep. I might have gone through it, but I'm not in it because I'm on bone. There's nothing on bone here. The artery is further back, the deep artery. But if I pull my needle out and I went through that vein, you might not see a little drop of blood over here, but in 2 days she'll have a bruise that will percolate up to the surface. So whether I see blood or not, I'm prepared to put pressure on with a little bit of an injection. Before I start injection, what do I do, guys? What? You can aspirate if you like. I know I'm in a safe zone. What else am I going to do? This is the key. I told you, these are the best things that you have with you. Finger behind. I don't want the product. This is her aesthetic fossa here. The product will go all the way back here. Put your finger behind, and now it's a slow injection. Where am I looking? I'm looking at the skin of the area that I'm injecting, watching what's happening, And I'm looking to the glabella very quickly to look in my rear view mirror as I inject very slowly. Look at the plunger, how slow it's moving. I can inject this fast, but you have to say in your mind is I want to inject at half the speed that I think I should inject. And I'm only going to put in 0.2 cc's of product, 0.25. I'm prepared if I caught anything. Lucky day, I didn't. And we're going to hold some pressure. We can change that needle because I dulled it, please, to another 30 gauge. Whether you see blood or not, this is key. You don't want a patient coming back 2 days later that has yellowish green discoloration. Okay? Because that bruise will come up to the surface and they're going to have trouble covering it with their hair. So, do I stop doing everything what I'm doing in my office? Time is money. Guess who you have as an assistant? So she holds a little pressure there and you go and do the other side. It's okay, I'll hold it for you now because I'm talking. We're going to be fine. And we're going to take a look and see what the story is. Did I do this for temporal contouring? No. I did it to soften a little bit of the edge over here. Okay? I did it to soften the edge. And I also did it to see, can I kick the tail of the brow up a little bit? Sometimes you can, sometimes you can't. So we're going to hold a little pressure. We're going to sit her towards the camera. And you can see that that the brow has splayed out now. Okay? And it's elevated. Look at the way we've taken, she was like this before. You see the way that we've taken up. How is that possible? How is that possible? She's saying. You're looking. How is that possible? The reason that it happens, and I'm doing a study now to try to figure this out, is very interesting. It's because of the fact that this is a muscle of mastication. There should be no effect on brow position. The brow position is being determined by the frontalis muscle. But interestingly enough, when you put product behind a muscle, the muscle automatically starts to relax a little bit. It's why your muscles in your back relax when you're sitting in a chair. So her temporalis is slightly relaxing now. The frontalis, which is the muscle next to it, says, wait a second. If that muscle's relaxed, I got to pick up the slack. It has a different function, but it's pulling up. The only thing that can elevate this is the frontalis. You'll see when we inject small amounts of product into her cheek that I'm going to get the corner of her mouth to come up. Is it because I'm putting in so much product that I'm getting a vector lift? I don't believe so. I think it's myomodulation. This is the next step in understanding fillers. So I'm doing a study now where I'm putting in little EMG probes into the frontalis and injecting the temporalis. When you have the probe in the frontalis, you get a background activity. Beep, 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 beep. I inject into the temporalis, and next thing I know, my frontalis activity goes beep, 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 beep. It's increased. But I'm not touching it. That's spooky. Because we were told there are no gap junctions between the muscles of the face. So how are they communicating? I don't know. Can't be centrally. You can't organize all the expressions of your face from here. It's too far away. There's got to be some sort of crosstalk that's happening between muscles. So we'll see how that works its way out. But when a patient comes in and says, Dr. Swift, can you do this? You know they love to lift their lateral eyebrows? I usually look at them and I go, am I doing it okay? They don't like that sense of humor either. But they say no on me. And I say yes by injecting a small amount into the temple. Like that. Okay. Good. That's temple. That's forehead.
You do the other side?
Sure.
Now,
While Kent is talking, I'll
variation of how I do it, because we're kind of Siamese and yet we're kind of cousins. So we do things a little bit different. But just a suggestion, I think I learned this from you actually, is when you inject into this little Swift spot, which is a centimeter down, a centimeter back, just like we've been talking about, as you inject, you lift the brow up.
Yeah.
Right?
Right.
And the reason you do that is you actually create a little strut work and a little bit of template of product that works maybe better than that side, just because of it, right?
Agreed.
Yeah.
Yes,
you could try to show them that.
We're gonna tack it a little bit.
Yeah, okay? It's just a little bit, and I do that a lot.
Just the small needle with the
only I prefer when you're doing that method not to do a blend. To use a straight up kind of product, either a Resty family or
perfect
type thing. Just
absolutely
just a different way of doing it.
If you take a look at the side, it's too bad that you can't see it. I don't know how
Very
much
nice.
you can.
Very nice.
Yeah. If you can come in and focus on this just a little bit. Let's see. Bingo. Okay. So if you look at this side over here, there doesn't seem to be any lines at all. And now you're getting the impression that she has a couple of little static lines on this side. You've actually relaxed the frontalis ever so slightly so that it's not causing any static lines.
It's a much better
Yeah.
here too.
There we go. So we're going to finish that off over here very quickly, or not quickly. We always take our time. When you're in a rush, I advise you to do this when you're driving a car too. If you're in a rush to get somewhere, slow down. That's when you get into an accident, is when you're rushing. That's why we see accidents at the last patient of the morning and the afternoon. It's also great when you're in a rush and you're trying to get somewhere and you start slowing down. It drives your wife crazy. So turn your head just a little bit this way. Okay, I'm going to keep my hands out of the way. We have the camera from above. I'm making sure you can see what I'm doing here. Notice that I pinch the skin as I put the needle in like that. It's a distraction, but what it also does is it drives the skin. I'm looking here, I'm looking here. It drives the skin up into the needle. And that's a much less painful way to inject than actually pushing a needle down into the skin. So I'll do it again over here. Slow injection. Watch here, there. See the little bump that's being created. You can see it. Be prepared to put a little pressure on and then just flatten it out. Okay? So this is the way that we do it. If I'm getting close to the temporal crest, let's say I had to fill a little area over here. I'm going to put a little injection in over here. I'm going to use more product than I normally would. Okay, slow injection again. Watch here. Here, I'm keeping my hands out of the way so you can see. There's the rest of my syringe. Pull it out. And now, milk it. Bingo. That's all it is. Okay? Foreheads, I love to do them. I absolutely love to do foreheads. It's amazing. Patients can have a little bit of a roller coaster for a day or two, but it goes away. The second the product heats up to body temperature, it'll flatten out even more. And then you use a little bit of arnica gel, which we have somewhere.
You don't use up the rest of your filler that you transferred into that insulin syringe.
Correct.
What do you do with that leftover?
I use it on the next patient. It's perfectly sterile.
Not from the BD2, from the syringe.
Not from the BD2, from the original syringe. I haven't touched the patient with it. It's all sterile.
They paid for the service and you're getting a second use.
I'm not charging per syringe.
Charging per syringe, correct?
Correct. I'm charging for the result. Let me ask you a question. Okay? And again, I apologize to the companies, but this is what I do in my practice. This is CME. I'm supposed to talk about what I do in my practice, and we talk about it
I wouldn't apologize.
freely. You would never apologize for that.
Not
That's
really.
for sure. Okay. You have to stop thinking Western. What I mean by Western thinking, guys, is the following. This is the way you were brought up. It's lunchtime. You come home, you run home for lunch, and your mother's there, and she puts down a plate of spaghetti in front of you, and she says, "Eat your lunch." You say, "Mom, I'm not hungry." "I don't care. Eat your lunch." "But finish your plate." Who's determining how much you eat? You? Your mom. Now you finish the plate and you say, "You know what? I actually was pretty hungry. Give me a second plate." "No way. You're going to get fat. That's enough. Go back to school." Who's determining how much you use? Your mother. Just because the company puts 1 cc into the syringe, does that mean that every patient needs exactly 1 cc? Okay. When you go to Japan and you sit down and you're going to sit down to one of the best sushi meals you've ever had, how do they serve you? 1 piece at a time. What do? You eat till you're happy. He taught me that. He said, inject until you're happy. So if it takes me a little more, I'll peel off some extra from the next syringe and I'll put it in. That's my practice. That's just the way that I do it. That's Eastern thinking. Whoops. Eastern thinking. Can I have the stuff for her temple, please? The Voluma. Whoa, one at a time. Let's hear.
Okay, if you're being Eastern, but the patient wants to know what she's going to pay when she leaves.
She knows beforehand.
Knows beforehand.
She knows beforehand. There's no sticker price shock.
What was she?
Okay? If she would come in and say to me, "Listen, Dr. Swift, I really don't like these folds over here, and I think that, I should really probably have these folds treated, and I want a little bit into my temples. I only have enough money for 1 syringe." I'm looking at her and saying to myself, she's a 2 syringe patient. Maybe 3, 2 syringe patients. How much money were you thinking of? She said, well, we have price for one syringe. Like I told you, $700. That's not a $700 case. So I'll tell her, well, if I can do the second syringe, I'm going to tell her, you know what I have in mind to do is $950. How much are you going to use? Whatever it takes. So you're off by a little bit. You use 2.2 syringes. The next patient, you might use 1.8. But this way, you don't get caught up on how much you're using. You're caught up on giving the patient experience and a result. That's all you have to focus on. That's all you have to focus on is experience and result.
What are your tier levels? So about 900, 950 is your first tier. What's your next
Oh, it depends.
Tier levels. I don't have tier
I don't
levels.
know
To be
tier
honest
level
with you,
either.
I do things for $450 or $500. I have a patient that comes in, just needs a little bit of filler in the upper lip. I'll use a half a syringe of product and I'll tell them, okay, it's going to cost you to do the upper lip. But you have a set price. Don't go by tiers. Go by a set price. Try it. Say, you know what, for a glabella, if you're doing toxin, it's $350 for a glabella. So some patients use 25, some patients use 20 units, and some males, you may take in a male that the price point is $400 for a male. And you use a little more, a little less, but you're not now worried about how much it's costing. You're only worried about generating the result. Crow's feet, $400, $350. So I tell them it's $350 and $350. How much are you going to use? Whatever it takes. You'll do better on some, you'll do worse on others, but trust me, at the end of the day, your bottom line, you will love it. I take out one of those little BD2s, or if I have to put in another syringe, I put in another syringe. I don't fight with the patient like that. And sometimes there's patients who just have to get their pound of flesh. Sometimes I offer them that extra little bit before they even ask for it. I have those little BD2s prepared with Voluma in it, or I might have Restylane Define in it. And the patient comes in and says, I love my result. And I'll look at her and say, you know what, I love it too, but there's a little bit of asymmetry over here. Let me correct it for nothing. For what? I just want to make it just right. You put in a little BD2, you put a little bit of product in, you pop up that little depression. The patient goes out and says, that guy's unbelievable. He's interested in creating amazing result. 5 more patients. It's the experience, guys. You're showing them the why. Why are you doing this? Is it to generate money? Might be that's the back reason. But the why is to create beauty.
Let's rock.
Let's rock.
Now watch, because we're going to do just a little different way here, right, Arthur?
Right. I'm going to feel for her
So we're
temporal
going to get
crest.
the Swift spot.
I've got to take a look. I'm in the dark here, but I can see there's a little vein over here, but we're going to fire in anyways.
And you could hold that up just as you enter the skin, or you could actually lift it up first. Either way is effective.
Small injection. Release. Again, no bleeding. Pressure. Change the needle.
If you have a little bit of oozing here, you could stop a garden hose with pressure. So just a little bit of pressure.
For sure. I told you, you're talking about if you ever have a bleeder, if you ever cut yourself, you don't have to strangle yourself on or stand on your hand to stop bleeding. You just put your finger
a little
down.
pressure.
That's all. What was the blend was 1 to 2. Is it the right blend, wrong blend? I don't know. You can use pure product. Use pure product if you want.
When I'm trying to create a lift to the contour, I use it straight up, but it's.
How long do I
both
keep
are
those
good.
blended syringes? They're prepared the night before by a nurse, and they're put into the boxes, back into the original boxes, and indicated exactly what's in them. Because Kent and I do a lot of patients during the day, we cycle through a lot of boxes. They usually get used up in the next day or two. But when I'm away and I'm teaching and I come back 2 weeks later, I'll use the same product. Is it the right or wrong thing to do? Don't listen
I do
to
the
me.
same. Yeah.
Don't listen to me. But I don't put them into the fridge like I used to, because the product that I've blended in is lidocaine with a preservative. I'm just telling you from my experience. You got to be sterile and careful when you do these techniques to go ahead and blend. If you are going to blend a little bit, you got to be sterile and careful.
What happens if it goes into the fridge?
Nothing. It just becomes hard to inject afterwards, and when you take it out of the fridge, it kind of gets all foggy on the inside, and sometimes a little bubble or something. I don't think it's terrible, but it's just more difficult.
Yeah, and the longevity isn't any different at room temperature.
And I don't want it sitting next to the pastrami sandwich or whatever one of my nurses might have popped into the fridge. I'm only joking. We have dedicated fridges.
I look
but I'm just
Italian
saying.
when you get done.
There we go.
Okay.
Does the epi can degrade the product if you put in too much epi? There's no question that epi will go ahead and break down the BDDE bonds. Can I have a marking pencil? The epi will break down the BDDE bonds.
So
And if you use too much of it, that's why I use a very small amount. Not a problem. Hasn't been a problem for me, even if you leave it stored for a couple of weeks, because I think the combination of epi and also the pH, because you're changing the pH. Remember, there's hydrochloric acid in the lidocaine with epi because that's how it's stored. If you drop the pH too much on the product, you'll break the BDDE bonds. But I haven't seen that at all. So I do a little bit different marking than Kent, but it's really 6 of one, a half a dozen of the other. How many ways are there to make change for $1?
There's 210 ways. Depends on if you have a 50-cent piece or not.
There you go. This is my idiot savant over here. You see that? Give him a number. 483,000 times. No, I'm just kidding. No,
And 16 different ways to tie your tennis shoes.
There you go.
At least.
A cheek is angled. It's ovoid in a female. It's no higher. I do it a little bit different. I draw a line straight across from the lateral canthus. It's no higher than the lateral canthus of the eye. You don't want to make a cheek up in the temple. Okay? And it should be a smooth contour. And as I take a look at her over here, I can see that she has that hollowing that Ken talks about a little bit over here.
Mm-hmm.
Okay? But she also has a little bit of hollowing over here. I'm going to leave this one, but this one I want to treat. I'm already started with Voluma. I have just a teeny little bit of Voluma left in that syringe with a fresh needle. I'm going to go ahead. What's the story here, guys? Can I inject superficial or deep? Either one. Which would you prefer? Cleanser? Superficial, deep, whatever you like. I can tell you that there ain't too much deep here to go. I'm going to go, and I'm going to go right down onto bone. I'm going to inject a small amount. I'm going to release and lift and put in a little bit more product like that. I'm prepared in case I hit something, which I didn't, and I'm going to tap it gently. And that little area is now corrected. You can do this with Voluma. You can do this with Define, Restylane Define. They both work beautifully well. You can do it with Restylane. You can do it with Perlane because you're injecting not into a space, but you're injecting into tissue. And the product will stay together. Okay?
How are you documenting these highly customized treatments? How are you documenting them in the medical record?
In the medical record, I write down 50/50, which shows me a 50/50 blend.
No, but the location of injections.
Oh, on your chart, on your diagrams, your staff does it. I don't keep track. They keep track.
Actually, when I start to do a full face, my nurse is writing down exactly quantity and what I'm putting
exactly
in
what
different
you're using, where you're using. That's
Correct.
all diagrammed out.
But most of the time, I remember pretty much what I'm doing, and I draw my little face, or I have a face that's already drawn, and I put in exactly what product I used and how much I used in each area.
And if whoever asked that question has enough OCD, what you do is take a photograph of it with the drawings on, and then you have that documented as well, and just photocopy it into the chart. But it's easier just to sketch it out. But sometimes we'll do that. We'll do all the drawings on the face and photograph it in our camera room, and then it's easier to document it. But generally, it's with the flow of what clinics like all of ours are busy. Then you have to, but you do have to have some record. But most places that I go for requests to go to their clinic type thing, very few clinics draw. So if you just start drawing a little bit, it patterns your brain, and it helps patients understand as well, and it gives you a better visual perception of what you're trying to accomplish. So not only measuring, but actually drawing. And so the reason I use these eyebrow pencils is choose ones that are really easy to get off. And I use a lot of these makeup removing pads. This is one, it's the medical grade from Costco. So called Neutrogena. Those are really good pads because they're soft and nice to take off all the coloring of your crayons. So tell them what you're doing there, Doc.
I haven't got a clue, but I'm having a good time. Here we go.
I wondered about that.
Here we go. I drew the oval. What the oval does when you draw it, first of all, it gives the patient the confidence that you have a plan. The second thing that it does is it draws your attention to the oval and you forget the rest of the face. Because when you're concentrating or focusing on the oval, you don't care about the gorilla that's coming across your face in the middle of your bouncing the ball. This is designed to take into account the facial height of the middle third, the distance from the nose to the ear, the position of the ear, the position of the nose. So what you're doing is you're drawing in the ideal malar mound, or mound, for me anyways, according to what I call my 5 principles, for where that cheek should be. And then next question is, once you develop that rounded cheek, you have to decide where is the apex or the height of the mountain supposed to be. The way that I do it, a little differently than Kent, but nonetheless we're very close in what we do, is I draw a line from the alar groove to the top of the tragus. It's a line that I do in my head, but I'm doing this for you guys to visualize it. Then I grab the lateral orbital rim, like this. I take the midsection or the midpoint of it and draw a straight line coming down, and I end up with something that's about over here.
That's pretty well how I do it. That's pretty well
And
the
if
same.
you measure the distance between her eyes, you'll find out that that point is exactly 1.61.
Yeah, 45 degrees out from your phi of your intercanthal distance.
I'll clean
And it's
it.
not, I think you have to remember, it's not a point, it's a zone. So it's not just one little dot where you're going to draw even though you may have drawn a little cross intersection of the highway here, it's actually a zone that you're going to treat to try to get that apex. And we usually, I think both of us treat the apex last, actually.
We do.
Sometimes you'll do the submalar part. And if you're trying to treat festoons and you want to create a little lift around it, then you've got to do that a little different. You're not on bone, you're in subcutaneous tissue, and you lift up that zone underneath the festoons, but you still do the apex last is a good trick to do.
0.02. I'm going to adjust just a little edge of it over here like that. And that's it.
Yeah, there he was in sub-Q rather than being on top bone.
Correct. You'll notice that I have this little technique, and I've seen Kent do it as well, that we have a tendency to lift the tissues with our needle. If you think about
needle
it.
and syringe, lift it a little bit. Then you have a space to fill.
And the product isn't doing work. Imagine if you're doing a bench press, you're lying on your back and you're trying to press weights up, but if you had somebody spotting and had already lifted the weight, you've gotten the weight to the same position, you locked your elbows underneath it, you've done no work. So I want the product not to have to do work. By lifting the skin, the product can ride up under the skin and you can set the skin back down in it. What does that do? You'll still get the same effect if you allow the product to push the stuff up, but you'll use more product because the product will spread slightly. This way I want to just rest it down on the tent pole. We'll clean her up over here. Remember, I've only used 0.2 on her cheek over here. That's it. 0.2 and maybe a little 0.01 over here.
You want to finish this side off, and then we can do the rest of the break there.
Yeah.
You want to finish this off?
Absolutely.
What do you
We're
want
going to do that in a second. I'm getting there.
Hang on, you're driving ahead of your headlights.
Okay. Let's get the face in there. Okay. Now you can see volume here, but what happened over here? What about the corner of the mouth here? It looks lifted. Can you lift the corner of a mouth with 0.2? Wow. You can. Wow. Yep. See, she says, no, you can't lift it with a 0.2. But look where the apex of the cheek is. There it is. That's where the light reflex is. And does her face look narrower or wider on that side? Right, but I added volume.
And it was fuller to start with.
I'm going to do a couple of quick things. Let me see the thickness of her skin. Because we have the product, I can use a different product on the other side. I don't know if that's legal in the U.S., but there's no reason. Here's a cleanser. Here's my little trick that I was talking about over there before, because I want to make sure we get it in.
Are we in the U.S.?
We're going to lift the skin, let the skin fall back down onto the needle. She shouldn't feel much. You're going to pull the skin up, like Kent talked about, and then I'm going to give it an extra little tug. You can see a little bit of movement over here. Look, that's SMAS. That's SMAS that's pulling it. I'm setting what I call a doorstop over here with a little bit of product, 0.05, and I'm going to do the same thing over here. Watch. I'm superficial. I'm 2 millimeters underneath the skin. Do you see this? I'm making a row of little injections. I can't do this with a cannula. And the reason I can't do it with a cannula is because I want to put in little depots. That's all. And I might do another little second set just above it. Okay? You following this? Pull the skin back and then use your needle to pull. Look. Use your needle to pull it back. Sometimes I pull up my needle. It's bent. 0.05 of product. Beautiful. Here we go. Can I have the arnica gel? Then I tell the patient, take your hands, hold this little pressure with the flat of your hand. That's all, not too much, just right. And now I want you to pretend you're giving yourself a facelift and push it up towards your ear and just hold it there. And I'll go and do the opposite side. I used Voluma over here that was blended down. I could use Volure. I could use Emerville Classic, which is now, sorry, I got to remember the names. It's now Refine.
Define.
Yeah, it's Refine. Okay, Refine would work well over here. I'm looking for a product because the Refine is a little more cohesive. I need something that's cohesive. I just saw a doorstop as we were going out. What you're doing, let me hold this for 1 second, is as we age or mature, what happens is your skin slides forward because you lose volume underneath it. Those little false ligaments are now sitting like this. Okay? You pull the skin back, so you're now pulling the ligaments to their neutral position. You put your needle in, and now you're pulling on the ligaments which are attached to the SMAS, so you're pulling the SMAS up. Now you put in a small little bolus of product, 0.05, not a whole bunch, 0.05. You've put a doorstop in, so when the ligament tries to go forward again, there's something blocking it.
Oh, yeah.
Okay? Can I have the arnica gel, please? So typically it's 0.05, 0.05, 0.05, 0.05. Right? And if I do that in 2 rows, I've used 0.05, 0.05, 0.05, 0.05 gives me 0.2. Doubled is 0.4. It's less than 1 syringe to do a patient's face. You can use the product pure. Or because I didn't have, I had it loaded in my syringe. You take a look at the thickness of the skin. If she's very thick, you can use like a product like Define, or you can use a product like Voluma. If she's a little bit average or thinner skin, I'll use the Volift, which is your Volure, or I'll use Refine. And then I go ahead and I just massage. This is just like I showed you in that little thing. Okay? Simple as that. Look at the difference on the jawline, guys. It's a wow. It is a wow. This is a practice booster. Look at what's going on over here. Look at this. What did she say? She can't believe it. You can't believe it. That's a little reset. Now that's different than doing what Kent has shown us with respect to contouring, which I think would be a good idea on her too.
Yeah.
It would be a great idea to contour her over here as well.
Then you get the real wow.
Let's hear it nice and loud.
Pre-gel.
See, now I got you thinking. Absolutely. Sure. The ligament over here that Kent was mentioning, which is the mandibular ligament, goes an osteocutaneous. It's from bone to skin. That one doesn't stretch. It's thick. So what happens is as your face starts to drop, it's a tethering point. You're not going to be able to move that guy too much. You're moving the skin that's posterior to it a little bit, and you're still going to have that little depression in the front. You're going to treat it as you would normally with the marionette zone. Right, Kent?
Do you ever subsize or detach that mandibular ligament?
No.
No.
In a facelift I would, but not in an injection.
No advantage to try to break that up. It just creates swelling.
There are like 5 true ligaments in the face, osteocutaneous. You have one up over here. You have what's called McGregor's patch or the zygomatic ligament over here. You have the mandibular ligament over here. You have a buccal ligament over here. These are true ligaments. And you have also the orbital retaining ligament, what we call the nasojugal groove, okay? Orbital malar ligament. They're there for a reason. They're supporting the tissues of your face. I'm wondering what's going to happen if we're constantly subcising and releasing those things. The patient would look good immediately, but what's going to happen in 5 years or 6 years? Are we going to get a rapid descent of the face because of it? Okay? Come on. This is what we're trying to do. Look how little product I've used on her face. I haven't even used I maybe used a full cc or maybe 1.2 cc's of Voluma that's been blended 1/3.
Yeah.
I haven't hit a 1 cc mark yet. I've done temple, I've done cheek, and I've done the jawline. That's why to me, maybe not even, she's saying. This is the key, is to use little bits of product to get the best. It's an economy of product. Do we have to take a break now? We're good?
Oh, we're going to got 7 minutes. Can we do her
Yeah.
jaw angle?
Okay, so watch jaw angle. I'm going to have Kent direct me on the way he does it. I'm going to do one thing before he does. Can I have a little bit of that Volum on a fresh needle again because we're using it? I'm going to do the next patient with Define because you can do this with both products. Okay? This is the gonial angle. Vertical ramus, horizontal ramus, that's the gonial angle right there. Okay? You can feel it in your fingers. What happened is that her jawline is now, instead of being like this, is like that. So I have to define that little gonial angle. You have it? Can I have a cleanser, please? I only have 0.2 or 0.25, which is perfect. This is the only time that I break my rule about superficial or deep over here. I'm going to feel for the gonial angle. I'm going to try to do this keeping my hands out of the way. You're going to feel a small little stick. I'm down on bone. Okay? I'm on the actual gonial angle. To be honest with you, I've probably gone through maybe a couple of little parotid gland issues over here, but I'm on bone. I'm not in the parotid. And I'm slowly starting to inject. Where am I watching, guys? Right. I'm watching where I'm injecting, and I'm glancing over to the glabella to see if anything is in the circulation. I'll start to see a little blanching. Look how slow the plunger's going. I'd love to do it quicker so you can get to your break and have your coffee, but I won't. Okay? Slow injection like that. And what I'm doing is I'm building a pillar over here for Kent's little technique of doing this and that. Out it comes. We haven't drawn a drop of blood yet on this woman. Do you have any blood in your system?
Let's check you out here.
There we go.
Oh, yeah. You're
Chin over
going,
here?
doing good, Faye.
Good. We're starting to create that angle. Do you see that? What do we have the patient do now? Can I have a marking
Here you go.
pencil?
Here you go. Got it. Got it.
Right. I'm sorry? 0.25. 0.2. 0.2, yeah. Give me a clench of your teeth, please. She's got baby masseters like
Yeah,
me.
there are babies.
Like mine are. That's the anterior border of her masseter. Here's her pulse. Yay! So, as Ken says, we
Be careful to draw that out really accurate here where that border is, because you start injecting, it kind of it disappears a little bit.
So we're going just about a centimeter in front. That artery is right there. Right there. Cleanser, please. Kent, what would you like me to use over here, product-wise? And what would you like me to do cannula-wise?
You can use several. I would use straight up Volure myself there.
You don't have it. What else?
You have it.
Oh, do we?
Yeah, you have it.
Okay, so we'll use it. I'm sorry, we didn't have it before, because we're staying with Allergan on this side.
Yeah.
I think I'll do Allergan on the other side, and we'll do the entire
switch
next
around.
patient. We used
Sure.
a little bit of Galderma product here. We want to make sure that we give everybody a chance.
So
Guys,
what size
it's
of,
mostly this, not what's in the syringe. Okay? In the syringe, you understand the different variabilities of the way that the products work. But really, it's technique-wise. Kent, you want me to use a 25 gauge cannula
you
here?
want to use.
Sorry?
From your box, what cannula do you want to use?
Is a 27 long enough to do the job? I'll use a 27. Let's use a
25 gauge?
Yeah.
Use a 25 gauge or 27?
Okay, here's a gray one, 27, and let's make it interesting. I'm going to take one of those extra needles that we had in that box of, give me a 27 gauge needle. Where are they? I'm going to make it a little challenge here. I like to challenge myself in front of people so that I can, okay? You got that? This is the lower border. This is where we're getting for. Is that correct?
Yeah, I would go on the upper border there, because then otherwise it may look a little off there.
Okay, no
Suggestion.
problem. So I'll go just above that.
Yeah, right in there, yeah. Good.
Okay.
Good.
Small little stick, not so deep, little spin. Dial in beauty. 3 to the right, 2 to the left, 3 to the right. So, okay. I'm going to pull it out, and hopefully she's not going to
Hang on
bleed.
there.
Okay. I only have the cannula. It's going to be hard to inject product unless I have product attached to it. Let me have the product, please. Here we go. Good. I'll prime it. It's okay, because I'm going to put my cannula on.
Where you
God,
putting
this
your
girl doesn't
stuff
bleed.
there?
That's great. We're going to see if we can find it. I hold my instrument like a dart. Ken holds it to twist and turn, which is perfectly fine too. I find this gives me better ability to find the hole because I'm more balanced. And once I go in, I flatten the angle out. Okay? because you don't want to go deep. And I start the product flow as soon as I start to push the cannula forward. It's a gentle flow as we go forward. Little pops. Those little pops are the false ligaments. There's something here called the mandibular septum. And those are ligaments that are coming up from the SMAS that are keeping your jawline from falling down onto your neck. What do you think? Take a guess. Yeah, 2 to 3 millimeters. That's my depth over here. I'm a superficial injector over here. And I'm going to just gently coax the product.
Yeah, he's in the sub-Q zone here.
That's right. And I'll do an antegrade and retrograde injection, just like Kent.
And that little popping you saw was the mandibular ligament. It's just like a speed bump. You don't really disrupt it. And then you just go down the other side of the street.
That's it. So this time now we're going a little more posterior. I'm staying superficial. You don't want to inject into parotid, guys. We've seen cases of patients that come back 24 hours later with a huge swollen parotid because the duct got blocked or they ended up having an abscess or a cyst. I'll do it from this side, so I'm going to change my hand position here so you can see it. And I'm going to inject along over here as well. Okay?
Notice he's going retrograde and anterior grade both, and you get a more even spread and balance.
I'm right now over my dot over here where I put in that little, that pillar. Small bit of injection over here, and we'll release that too.
And then let's see.
Look at the definition that we're getting here. I'm going to
watch
try to
when he blends that all in with his gel there.
Yeah, that's what I learned from Ken too. He was an ultrasound gel freak. He was always using his cool ultrasound gel, which is a great thing to do. I switched to arnica. Why? I don't believe that.
No, I don't think it
doesn't make a difference, but the patients love the name.
Arnica.
They think arnica is unbelievable. Sure, it might help bruising. Can I clean this up with a little bit of a wet sponge, please? It might help things when you take it sublingual, but I don't think there's really much skin penetration of arnica. It might help a little bit of swelling, actually. It's been shown around the eyes. But it doesn't do anything topically to prevent bruising. But the second I tell my nurse, get me some arnica, patients are so happy. Oh, I use that stuff and everything, so I just use, you can probably use ultrasound gel and say, pass me the arnica. But I'm just saying, but I wouldn't do that.
Pass me the ultra gel.
There wasn't a bevel on it. There's a side port on it. Do you care if the side port's up or down?
I don't
Kent,
care.
Do you care?
No.
I don't really much
I don't think
either.
it makes any difference at all. We've tried both ways, upside down, backwards. I don't think it makes in this location. It doesn't make any difference. So if you see now we're talking.
We're not talking. We're screaming. Now. We're screaming now. Okay. I'll do one last injection because we're 1 minute over, or 1 minute to time expire. Okay, 1 minute over. I want to show you how I inject the chin on this patient, then I'll do the rest of her when we do. I would like to narrow her chin because I think it's too masculine.
Yep.
I don't think she needs more height over here. I think she needs to have a little more of light reflex in the middle to give the impression that her chin is narrower. Since we're using Voluma, I'll stick with it.
You're
going to give it to me on a needle?
Feminization.
This is the trick that I do now, guys. Rather than injecting right down onto the chin like this, that hurts. If you've ever put in toxin, people don't really flinch when you go ahead and do that. I have this technique now where you lift the skin up like that, you hold the needle, and you let it fall in. What did you feel? Nothing. She didn't feel nothing. She felt nothing. I have her asleep now. It's tachyesthesia. Okay? Now I'm going ahead and injecting. If my needle is into the hub, that means that my needle is located here and the product will project this way. If I want to try to create more of a height to the chin, as well as a projection, my needle will come out halfway. And now I'm sitting on the curve of the mandible. Do you follow? So I want to do projection. I'm going back in. I can't go more posterior because I'm sitting on periosteum. I prevent the product from skirting up. She hasn't felt anything, and I inject slowly. What did I just check there? Absolutely. So I'm driving and looking in the rearview mirror. This is a great place for Define. It's a great place where I use Ultra Plus because Ultra Plus is the most cohesive of products. You need usually a little more volume here, maybe about 0.05 to go ahead and do this. I'm going to stop at 0.04 on her. Okay? One little drop of blood. And we're going to mold it. That was the blended. I would have used it normally straight up, to be honest with you, because you need in a chin as much of the robustness of the product as possible. Okay? That's why I love to use Ultra Plus.
You were on bone?
I was on bone this way.
This way?
This way. Yeah, I was sitting resting on bone this way.
Where was the bevel? Where was the tip of the needle?
The tip of the needle was over here, and I really didn't care whether it was facing down or up. If you can give me a reason for why I should care, then I'll change my technique and say that I figured it out. No, I won't. But by all means, if you have a reason for changing the direction of the bevel on an injection like this, please let me know. I'll certainly quote you. I give all the props to everybody. I've learned a ton from this guy. A ton. Beyond a ton.
Why not cannula in that case?
You can, but the cannula would be a lateral approach. Wouldn't be an inferior approach. You can probably try to do it. It's gonna be a little tough to do.
No advantage because you can't lift as well. Here you want reflation and contour, and you can contour nicely with a cannula, but it's hard there. Even though we're both cannula crazy, it's a room for both.
So
I've tried it, and we do both ways because we do lots of cannulas.
You can. If you want to use cannula, it's fine. The idea is here, when I think in terms of bolus, I prefer to use the needle down to bone.
Yeah, I agree.
When I think in terms of sheeting or of creating structure, I like to use a cannula with constant movement to go ahead and do that. So.
Her left jowl is slightly larger than her right, and so would your technique be the same in terms of making that side a little bit lower than the right side?
What would your technique be in that situation?
I would be very cautious about, I would try to
let me just.
Beautiful. So I might have used 0.2 or 0.3 here. I might end up using 0.4 or 0.5 here. Sometimes I double my lines here in order to be able to get a little more pull. I did this about a month ago in London, and they gave me a bulldog pretty much. I'm sorry for the woman who I had to inject, but she looked like Sir Winston Churchill's bulldog. She was square. And I couldn't obviously get rid of everything, but we made a big improvement in trying to lift up that. You can see the difference in the recoil of the skin on this side. It wants to stay up versus this over here. Look at the jiggle.
But her left mid-face, when you go to do that, her left mid-face, when you go to do that, she has many more undulations.
Yeah. That's.
Tell me what you're going to do when you do.
Sure, I'm going to do it at the break because we want to get you guys on the break. I'm going to go and draw my circle in. See, she has the already inflated cheek. She's already had fillers put in here. What I'm doing now is I'm contouring and I'm camouflaging. So in cases like this, I always draw to see my exact oval. And then I'm going to try to make that oval as smooth as possible by putting in small injections over here. I might even use a cannula if I have to go ahead and to contour that. Then like Ken says, we're going to do the apex. We're going to work down to the bottom part of the face. Everything you do on the mid-face affects the lower part of the mid-face because it's suspension. Everything you do on the lower face is structural support, so it lifts this part as well. But you cannot lift a chin from the lip. You have to work your way up from below like this.
Are you going to remove that little bit of tyndall she has on the left side?
I'd love to. She has a little bit of tyndall. And we'll talk about that after the break. How about that?
Let's take this off here for a minute. And just sit forward just a little bit. Just sit like that. Just sit forward a bit there. Faye, just sit forward a little bit. Put your head like this. Head back a little bit.
Look at the jawline. Come on. And this is the ideal patient to do that on. Why? Because she's had previous surgery.
See what I'm doing here with the light, you guys? We're just creating a little bit of light. And create the shadow. You see, now we got the shadow back. And then you don't see any shadow, so now you take the light and you got the shadow there. See?
We're good?
It's another Canadian trick.
Yeah. You're very good.
Thank you.
You're great. So guys, take a break. I'm going to finish off. Maybe we'll take a peek at her afterwards. We'll get another patient up. We'll try to demonstrate other things. You call it from the audience. Whatever you want us to treat and how you want us to treat it, we'll be the hands, you be the brains. Enjoy your break.